Thank you, sir.
Okay.
Hello.
Hello, doctor.
Hello.
This is 65-year-old male patient complaining of dyspnea.
So again, stent. I think okay. This is chest radiograph frontal projection of adult patient having history of dyspnea. Also, the upper abdomen is also included. I can see that the esophageal stent is
Really?
appreciated in the lower half of the esophagus extending into their stomach. I can also appreciate their stomach bubble. Now there is no evidence of pneumoperitoneum. Now I'm looking at the lung fields. In the lung fields, there are increased opacification in the right lower zone, causing partial silhouetting of the right cardiophrenic and the costophonic angles. There is also somewhat airflow level in the paramediastinal location, and these areas also show airflow levels in it. The rest of the lung fields are unremarkable. The visualized soft tissues and bones also seem to be unremarkable.
If I told
So,
you, the patient has sudden pain, sudden severe chest pain, what?
okay, then then there would be some complication of the stent. There could be some stent rupture or perforation at the site of the stent.
What is your next
Uh,
step?
I will urgently inform the finding to the referring physician to suggest contrast enhanced CT chest and abdomen for further characterization.
What type of contrast would you use?
Um, this I am Omnipag, no smaller as already,
Low osmolar?
because
Low osmolar.
no Omnipag
One
or
second. Would you use barium?
no, I will not use
Okay.
barium because it causes mediastinitis.
Yeah. Can you use water soluble, or better you use
Uh,
something else?
so water soluble, if it is gastrographin, then I will not use, because if there is there are any chances of esophageal tracheoesophageal fistula, then it causes rapid pulmonary edema, and it is not safe.
So
So
it is
low
better.
smaller contrast, the Omnipag.
Yeah, it is better to use low osmolar contrast. Okay.
Omnipag. Yeah, in this there is these are I think not scrollable.
Yeah. What happened?
So these are spots from the upper GI examination. These the contrast contrast swallow. I can appreciate that the contrast is outlining the upper and the cervical and the upper thoracic esophagus. I can see that there is contrast extravasation or contrast pooling in the
What's
mediastinum.
your diagnosis?
This is likely the perforation at the site of the previously placed esophageal stent, um, causing mediastinal leakage. So, as this is the emergency, I will urgently inform the findings. The referring physician will suggest referral to the thoracic team for urgent repair and further management.
Thank you, doctor, so much. Next candidate. Next candidate.
Hello, good afternoon.
Good afternoon. 45-year-old male patient has dysphagia.
Okay, so I'm requesting the remote.
No need. I will scroll for you. What happened here?
Okay.
What happened? No need. I will
Okay,
scroll for you.
okay. So I can see that there is dilatation of the proximal cervical and upper thoracic esophagus with the
Yes.
yeah, so there is well-defined area with air fluid level is seen in the along the distal part of the esophagus. So it may I have the axial images again? So there is dilatation of the distal part of the esophagus. With there is a
What?
seems to be a
What?
diverticulum extending
Yes,
from the
yes. Why?
central
Why?
wall.
Why? What
So
type?
it's
One
maybe an
second,
epiphrenic.
doctor,
Yeah,
listen to me and raise your voice. This is a dilatation, okay, but what type of dilatation? Fusiform, eccentric? Tell me.
it's eccentric and it is
So,
extending
yes,
from
yes,
the
yes.
right lateral wall of.
Listen to me.
Yeah.
So, it is diverticulum because it is eccentric. What is your next step?
So this is epiphrenic diverticulum. So I will convey the finding to the reference physician and further evaluation and management with the cardiothoracic team.
Do you want to do any study?
Yeah, we can go for upper GI and contrast studies. So
Yes.
on provided serial images, I can see that there is an outpouching which is
What
extending
is
from the.
what is the name of this study?
This is barium swallow and barium meal
And
because I can
and
barium
see,
meal,
and see, read.
barium follow through,
Yeah,
barium
maybe
follow
follow
through.
through even. Yeah, excellent. So this is a case of.
Epiphrenic diverticulum.
Thank you, doctor, so much. Next,
Thank
do you
you.
know the different type of esophageal diverticulum?
Yeah, in the upper part, there is Zenker diverticulum.
No,
Then there is
no, no. I'm not asking about the names. I'm asking about types.
uh, I don't know exactly.
See, there are this diverticulum, and this is one of the pulsion diverticulum. Why? The pressure inside the esophagus increased, so the mucosa herniate. Okay, so
Mm,
this is pulsion diverticulum. But when there are inflammation like mediastinitis, okay, there are fibrosis here. The fibrosis exert on the esophagus a element of pulling power, pulling attraction.
Traction,
So,
traction,
so it caused a cicatricial
traction.
effect. Okay, a cicatrice. So
Okay,
we have a pulsion diverticulum, and the other one
traction diverticulum.
traction. Okay, this is
Yeah.
types, not name. The name is epiphrenic. Thank you,
Okay.
doctor, so much.
Thank you so much.
Next candidate.
F12 is if not present, 13 please proceed.
Yes, go
Okay.
on.
Assalamu alaikum, sir.
Wassalam. 90-year-old
Sir,
male patient with dysphagia. What's your diagnosis?
direct diagnosis, or I should describe it.
No, no, give me diagnosis.
Uh, sir, I've been tertiary contractions, corkscrew,
Yes,
esophagus.
excellent. What is the name of this disease?
Uh,
Corkscrew esophagus in 90-year-old patient.
Sir,
Okay.
maybe it may be diffuse due to diffuse esophageal spasm.
Yes, yes, excellent. What is the name of this spasm? Hmm.
As far as I remember.
Esophageal dysmotility. Okay.
Okay,
Esophageal spasm or esophageal dysmotility. What
okay.
history should you ask about in this patient?
Um,
Or what is the underlying cause of esophageal spasm like this corkscrew?
Sir, maybe due to absence of some neurogenic plexus in the distal
Yes,
esophagus.
yes. See, at least tell the examiner it is a neurogenic problem. Thank you so much.
Yes.
Like this.
Yes.
Okay. So it is due to underlying neurogenic problem, whatever the name or which type of neurogenic, but at least the examiner knows that this is related to a neurogenic problem. Thank you, doctor, so much. By the way, it is very painful, and they give some nitrates, some very strong drugs to relax this spasm. Very painful, my colleagues. Thank you, doctor, so much. Next candidate.
Yeah, sir, I'm candidate 14.
Welcome, 90-year-old male patient. Look here.
Okay, sir.
What happened?
Sir, in this particular case, there's significant aspiration on the tracheoesophageal layering of contrast is seen, and it is outlining the anti-bronchi on the
Okay,
both.
if I told you there are no contrast because this is controlled.
Okay.
The rest of this film, the upper part, because this is not scribble, the trachea is normal, no any contrast in it.
Okay.
So what
Okay,
is
sir.
this?
So then there is fistulous communication for any
Yes.
if any previous contrast study of esophagus may lead to fistulous communication, and
If
then
I told you this is a 90-year-old male patient, so what is the cause here?
so the most likely is malignancy in this age group, which leads to fistulous communication with the esophagus and the trachea or bronchus directly.
Thank you, doctor, so much. So this is a fistula between the trachea and this is the trachea. Esophagus. Why? Look at the upper trachea. Okay, here no trachea. So I told my colleague it is no contrast. So the other possible diagnosis is fistula. In old age, malignancy is the first possible cause.
Thanks.
Next candidate. Thank you, doctor.
Yes, sir. Assalamualaikum.
Assalam. Long-term heartburn.
All right, I'm presented with fluoroscopic images of barium swallow. The contrast is seen from passing from esophagus into the stomach. However, I can see that there are multiple linear reticular folds seen in the region of the distal esophagus. However, there is no pull-up of contrast is noted. These linear reticular opacities in the region of distal esophagus are concerning for Barrett's esophagus. It is also associated with some structure in the mid esophagus. I want to have a look for that too. Otherwise, I will convey the findings to reference clinician and will advise endoscopy and biopsy.
What's your
These
diagnosis?
patients,
Doctor, I didn't listen your differential.
yes, my differentials will include Barrett esophagus or any underlying esophagitis.
What is Barrett
These
esophagus? What is Barrett esophagus?
Barrett esophagus is the metaplasia of the distal esophagus from the replacement of the columnar epithelium from that of the stomach. Squamous epithelium from the
Due
due to
to
the gastroesophageal reflux disease.
yes. What should you be worried about?
I'm worried about the developing malignancy as these patients are prone to have adenocarcinomas in the distal esophagus.
So thank you, doctor, so much. This is a Barrett esophagus. See, my colleagues, the mucosa should be like this, longitudinal. But look from here down, everything is destroyed. Everything, see, another. It looks like fibrosis in lung. Why? What happened? What happened? Somebody will tell me, doctor, it is not clear for me. Okay, look from the beginning. This is the mucosa, the black one. And the white one is the contrast. Mucosa, contrast, almost mucosa. Look here, it is very clear. Mucosa, contrast, mucosa. Okay, very clear. Go down. What is this? See, you can see the contrast filling here. This is mucosa. Okay. Then contrast, transverse contrast. and some contrast here. This is contrast inside the mucosa. This is erosion. And then the contrast come. This is the normal track of contrast. Cut the mucosa here and go here, like a war. Interruption of the mucosa, especially at this area, very clear. Interruption of the mucosa means esophagitis or something abnormal here. So our doctor told us there are reticulation. This is great and a very important buzzword. The contrast here, see all of this, by the way, my colleague, you should see black column and white column, black and white. See here, no this normal black and white. What happened? Almost white, I mean contrast, and inside it contrast, inside it black. What it mean? The contrast creeping up or invade the mucosa. Why? Because this is erosions. Okay, so this is a parietal esophagus due to chronic reflux. It is a precancer. This patient must underwent a biopsy and follow up. Okay, my colleague. This clear? Really,
Yes,
when I was candidate for FRCR, I didn't understand what happened. But another read for the topic when you are relaxed may give you the correct information. Here, Barrett esophagus, because Barrett esophagus is not a very obvious disease. It is a borderline between normal and abnormal. How to detect it very easily? Look here. Look here. See? This is a mucosa. This is a mucosa. Between them, contrast. Mucosa contrast. So alternative mucosa contrast. Like rugger jersey shirt of this football team or American football, I don't know. But alternative white and black, white and look here. The issue is not like this. Areas mucosa cutted by the contrast. Why? Because this is erosions. Is it clear? Even here. Any question for this part? Because it's a little bit confusing. Thank you, doctor, so much. Next.
thank you, Doctor.
Thank you. Thank you. Next candidate.
The main list is finished, Dr. Rami. We can
Yes.
proceed to the extra list, or you
How
can say
many?
next
Yeah,
session.
yeah. No. How many we have in the extra list?
No, there are a lot, maybe about 10.
Yani I will take some until I lose conscious, until I lose my energy.
Okay, that's fine. So
Okay.
candidate 16, 17, anyone present can proceed, please.
Anyone ready?
Okay, can I have this case?
Yes. Dr. Nagam, this
Okay.
patient has chronic reflux. Go on.
Okay, so I'm presented with a series of barium swallow for a patient who is complaining of recurrent reflux. I can see there is an irregularity of the outer lines of the esophagus, involving almost the entire esophagus, with multiple outpouching on both sides, which appear parallel, uh, filling with tiny amounts of contrast, which are not connected in all of them. Yes, the contrast is seen passing down to the stomach. No evidence of contrast leak. So my differential for this would include pseudoesophageal diverticulum.
Okay. But let me help you
Yes,
to confirm the previous explanation. Could you see the normal alternative mucosa contrast pattern?
no, there is shaggy appearance of the esophageal mucosa, which could be represent candidiasis.
Not candidiasis, yani generally osteophagitis, because candidiasis is a type of osteophagitis.
Okay,
So look here, we lost the normal pattern. So what is this?
okay, this is esophagitis, yes.
Okay, and what is this? By the way, here, my colleague, the contrast is black because this is negative. What is this?
These are diverticular, yes.
What is the name of
Are
this?
all oscillation.
Hmm?
It is either pseudo-diverticuli or due to
Okay.
ulcerations, or these are the ducts of the esophagus that are filled with contrast going to the canals.
Okay, see, the Radiopedia said this is pseudo-diverticular, no problem. So overall, this is a case of esophagitis. It may be due to candidiasis, due to any other pathology, but overall, losing of the normal longitudinal mucosa contrast pattern is a sign of esophagitis. Look here. What is this, Dr. Nagam?
Ulceration, yes.
Excellent. And what is this?
Another ulcer, yes.
See? This is the pseudo-diverticulitis. The pseudo-diverticulosis. Thank you, Dr. Nagam. Next candidate.
Thank you.
Welcome.
So can I take a turn?
Okay. Doctor, this is 30-year-old female patient. Consider she has a dysphagia. Go on.
Okay, sir. I am provided with a spot image, frontal projection of a barium swallow of a 30-year-old patient. I can appreciate that the esophagus is dilated seen throughout its coat and at the distal end of the esophagus. Very smooth tapering and narrowing noted. I would like to review this on further images to look for the persistency of these findings. If the other images are and whole of the barium series is available, to look closely at the lower end and to look for is it persistent or opening on the other images. And I would also like to review the contrast passing into the stomach or not. Sir, so this is likely benign looking narrowing involving the lower end of the esophagus in the provided images.
Again, what's your diagnosis, please?
Sir, it's a benign looking narrowing involving the distal esophagus. However, I would like to
No.
review this.
See, look here. Is this narrowing or dilatation? Look here.
So there is dilatation and shouldering. Now I can see there is
I will help you.
shouldering as okay.
What? No shouldering. What is this? This is
Okay, sir. So this is X-ray hand frontal projection, and in this I can appreciate that there are changes of acrosteolysis which are involving the distal and calcifications. Calcificus cutis. Yes.
And soft tissue.
Soft tissue calcifications
and atrophy.
And calcium atrophy. Yes, sir.
So, see, doctor.
Sir, scleroderma. So this is patchless dilated esophagus.
This is a diaphragm. This one, I think, because it is below the spot. This is diaphragm. This is the dilated or narrowed.
So dilated.
Yeah. What is the name of the dilatation here? This has a
dilated patchless dilated esophagus.
Patulous esophagus. Doctor, why in scleroderma the lower esophagus dilated? Why?
Sir, because it is the connective tissue disorder, and it is. So it affects the connective tissue of the lower end of the esophagus, so they are dilated.
No, see, scleroderma is a connective tissue disorder. I agree with you, but for the GIT, scleroderma cause a whole uniform pathology for the esophagus, small duodenum, small bowel. The scleroderma as a disease affect something specific in whole GIT. Is underlying pathology. Smooth muscle infiltration.
Okay, smooth muscle infiltration. Okay.
So the esophagus dilated, and a small bowel also will be dilated besides the height-bound sign. Affection or infiltration of a smooth muscle, so the esophagus loses its tone. Okay?
Okay.
So it was a case of scleroderma. Thank you so much. Dr. Anagam, do we have any candidate?
And the next candidate?
I am.
Yes.
I'm here.
I'm candidate 24.
I'm candidate 15.
Patient को भेज दो.
Which one?
19 is there. Would we give him priority, please? 19.
Yeah, sure.
Yes, sir. I'm 19.
19, okay. Raise your voice, doctor.
Yes, sir. Assalamu alaikum, sir.
Alaikum salam. 8-year-old male patient presented with recurrent pneumonia.
Okay, I'm presented with upper GI contrast study of an 80-year-old male patient presented from recurrent pneumonia. So this is these are the images from upper GI endoscopy, in which I can see that there is a diverticulum noted. No, there is aspiration noted from the upper esophageal level down into the bronchial tree. The contrast is also outlining the trachea and all the left and right major bronchi as well.
But I
There
think,
is
doctor, I think this is fistula.
okay, sir.
No,
Sir,
no,
there's fistula.
no, no. 1 second. I'm just discussing with you. I have
Okay, sir.
this is fistula. Is it true or not?
Sir, can you please show me the second image that you have shown me? The lateral projection at the yes, sir, this one. Sir, yes, this can be fistula, but this can be a pathological fistula because at this age, congenital fistulas are less likely.
Doctor, what is this?
I think
What
some
is this?
mucosal irregularity.
What is
Sir,
this?
this is likely an outpouching.
No, doctor, what is this?
So this is trachea.
Yes, what is this?
This is esophagus, and there is stricture narrowing.
What happened in the trachea? What happened?
So the contrast is being aspirated into the trachea.
Okay, so this is a case of aspiration or fistula?
Aspiration. Sir, then it's aspiration.
Very nice. Correct. As I told you, all of you, many times, the first answer that came in your brain is almost the best answer. See
Yes.
how to differentiate or to reveal this is the trachea. Look, the trachea ring and the mucosa. Ring and mucosa.
Yes.
The ring causes, the cartilaginous ring causes some indentation. This serrated border. And the trachea is the most important. It looks like just subcutaneous, very near from the soft tissue. Okay? So
Yes.
was a case of contrast
Aspiration.
aspiration. Thank you, doctor, so
Yes.
much. By the way, this case
Yes.
may the examiner use in the exam? Yes, sure. I was given a case of just bilateral breast edema. The examiner gave to me, and they want from my side to go through tumors, everything that we are talking about. But finally, the answer was very simple. It was a bilateral breast edema. Okay?
Yeah, okay.
Even the edema was only in the skin. And the examiner want from me to talk about generalized cause. Very simple. Okay? Thank you.
sir.
Next candidate.
Candidate
I'm
21,
candidate
please proceed.
22. Sorry, I'm
21.
candidate 20.
20? Okay. تفضلي.
21 is the
20?
We will take 20 first, sorry. 20, then 21.
Okay.
okay.
I think this is the same case. Okay, doctor. 35-year-old female patient with dysphagia.
Okay, sir. I'm presented with upper GI contrast swallow study serial images of a 35 years old female who presented with dysphagia. So I'm looking at the images. The top image show normal pacification of contrast, and the one that is being projected now, it shows that there's some tubing noted within the thorax. But other than that, I can also see that there is in the area of non-opacification of contrast within the lower esophagus at the region of the gastroesophageal junction.
Brilliant.
It shows mucosal irregularity in it. And I do not see any extravasation of contrast outside the confines of the esophagus. and there's no abnormal fistulous communication and no aspiration in the current studies.
What's your
Based on these
diagnosis?
findings,
Diagnosis?
I'm thinking because there's some mucosal irregularity in the distal esophagus and the gastroesophageal junction, I'm thinking this could either be a luminal cause or it could be an extraluminal cause. May I know the history of any previous intervention in this case, because I see some tubing in this.
Doctor, look again here. You see, 2 seconds ago, you were in the correct pathway. Describe again. What is this?
Okay, so
It is a
based
structure.
on mucosal
1 second.
irregularity, I'm
1 second. This is structure. Second step, you should tell the examiner, is this benign looking or non-benign at least? Not malignant, but not non-benign. Do you think this is benign or malignant structure?
No, I don't think this is a benign looking structure because I see mucosal irregularity and the
And
contrast
what is this?
and shouldering
Yes.
at the proximal end of the structure.
Yes,
So
so?
this is likely an aggressive looking lesion.
Okay.
So I will advise an endoscopic ultrasound and biopsy for this patient. Further workup with staging CT abdomen and pelvis and discussion in MDT for this patient.
So this is lower esophageal cardia, distal esophageal and gastric cardia carcinoma. Okay?
Exactly.
And by the way, my colleague, in our practice, most of us didn't look at this area well. I know I have one bad experience, not for me, for somebody. He has an interview with very good place. Okay? And they gave him one case, but it was CT with cardiac cancer. Okay? And he didn't, I think he didn't see it, see the cancer. And subsequently, he was rejected. Okay, my colleagues, take care from review areas. Greet my doctor. Look here. See? See the shouldering? This one.
Yes.
Very clear. And this is the lumen. My colleague, in our practice, we better to see the serial images because it is better to see is this lesion will disappear or not. Okay? Thank you, doctor, so much.
Thank you so much.
Thanks so much. Next candidate. Next candidate.
Yes. Yes, 21.
Assalamu alaikum.
Salam. I see, doctors. In this case, I don't know. Is this a sickening of the stomach or the the urology or not? Why? Because number one, we must see a serial film. Number two, the stomach must be more full than this one. Okay, at least you can tell the examiner this is there are nodularity of the fundus. Okay, we don't know for either serial following the examination in serial images and waiting for the stomach or giving more and more contrast, and it is better to be double contrast like this. Like this you will save yourself. Okay, my colleagues. Thank you, doctor. Next. Hello.
Assalamu
Assalamu
alaikum,
alaikum.
sir.
Which one, doctor?
21, please. 21.
21.
Yes, sir, I am here.
Okay, welcome. See,
Thank you.
doctor, this is very nice case. 70-year-old female patient with reflux. Okay, what happened
Okay,
here?
sir. This is axial CT post contrast. Soft tissue window. I can appreciate multiple loops, fluid-filled dilated loops of the small bowel.
Okay. What happened for the
Stomach is
duodenum?
also.
Look at the
Stomach
duodenum.
is also.
Yeah,
Yes.
Look at the duodenum. What happened? What happened for the duodenum?
Second, I have axials. Yes.
Yes.
Mm.
Hmm. What happened for the fold? Hmm. What happened for the folds of the small bowels? Increased or decreased?
I think increase in the proximal. They are normally
Okay.
jejunal folds are more than yes.
And what about the distance between them? See?
Mm. Sir, in the jejunum, I think the folds
All the
are a
folds
bit
is increased. See,
thicken. Yes.
see. Bowel dilated whole.
Bowel is dilated and fold is thickened.
Yeah.
I would like to see distal esophagus as well, if I can.
Excellent. What's your concern, my doctor? This is a distal esophagus.
I was thinking about scleroderma,
Is the esophagus dilated
uh,
or not?
esophagus.
This one.
Yes, I think yes, it's dilated.
So,
Yes. So I think this goes for scleroderma. I would also like to see the lung window to see any changes in the lung basis.
I think we have only this one. What
Okay.
happened here?
Okay, there is a dilated esophagus distal,
Yes.
also in the proximal, and there is, I think, ulceration, reflux esophagitis with the
Okay,
ulcers,
okay.
ulcer formation, thickened folds.
See. This the mucosa of the stomach. And
Yeah,
here is the
esophageal
gastroesophageal junction.
junction.
How
Yeah,
can
this,
we know it? Number one, by changing the mucosa from longitudinal to oblique, and the rouge is more thicker. Okay?
yes,
So
yes,
the end is dilated or not?
yes, it is. Yes, it is.
So what's your diagnosis?
Uh, so I still stand with scleroderma, I think.
Excellent. But
Yes.
here, can we diagnose from this image reflux or not?
Reflux, yes, in early, I think early reflux, there is dilatation, but in chronic stage, it leads to stricture formation.
See, doctor. There are any
Yes.
clue here that the technician asks the patient to do any Valsalva? No. The film, no. See, to diagnose reflux, we must ask the patient to do Valsalva or to drink something or to sit in Trendelenburg position. The film here didn't any notes has been written on the film. Okay, my doctor?
Okay.
Okay, so don't judge about the reflux without any annotation, or the examiner will tell you, Doctor, this film was taken during Valsalva. The patient was in supine position, and we give him some contrast like this. You must have any evidence that we are doing a test for reflux, siphon test.
Okay.
Okay. Thank you,
Okay.
doctor, so much.
Thank
It
you.
was a case of scleroderma. See here, the esophagus is dilated and all the small bowel is dilated. Look at my colleague. See, abnormal, abnormal increased number of the folds and decreased the distance between them. Okay, the height bound sign, height bound sign. It is mainly described in the duodenum, by the way. Okay. Height bound sign. This is the duodenum. Okay. What happened? The scleroderma infiltrate the smooth muscle. So the GIT lost its tone. So it is dilated. Dilated. So my colleague, when you see a dilated bowel in non-acute patient, and look, please look at the folds. By the way, they will not bring a case with calcification here. Because if they bring case with calcification, all candidate will answer it. They must give some confusion for the candidates. Okay? See my colleague? This is the duodenal cap. Follow it. Follow. This is the duodenum. Okay, this is the fourth part. By the way, even I see in the jejunum there are increasing. This is the proximal jejunum, increasing the fold number and decreasing the distance. Okay, my colleagues, is this clear? Beside the patulous end, don't forget to tell this very important buzzword. The most important buzzword of the scleroderma is this one, patulous end of the esophagus. Do we have any candidate? Last one, Dr. Nagam.
Yes, I
22
am
is
here.
here.
I'm 22.
22?
We'll keep order, yes.
Yes. Uh, okay, this is 40-year-old male patient. This is static image, my doctor.
Oh, okay.
Doctors, you
Yeah,
when the image are scrollable, most of you forget today.
no, I just for the
Not
other
you. Not you.
images.
I'm joking, not you.
Okay.
But very good from you.
Okay.
40-year-old male patient presented with dysphagia. This is, yeah, go on.
Okay, this is barium swallow, lateral view. Um, um,
This is AB. This lateral.
okay, this is AP, and this is lateral view.
Mhm.
This is oblique view. So I can see that there is mild dilatation of the entire esophagus with tapered distal end.
Mhm.
I can't see any mucosal irregularity or fixed filling defect.
Okay.
Can we go back to yeah? So
See. Again. Look here and here.
okay.
Look here. What about the contour?
Hmm.
What is this? One
There
by one.
is
One. See. My colleagues, fluoroscopy is also difficult because most of us يعني, is not familiar with it. Even me, frankly.
hmm,
So one by one, this is the first lecture.
this is-
Any mistakes is very acceptable and welcome. But here, not in the exam. Okay? We look at the AP, no any filling defect. The lumens looks like, yeah, maybe looks
hmm,
like here, good. What happened here? Is this contour is like this one?
no. There's
Okay.
smooth long segment indentation.
Excellent. And what happened here?
Um,
This indentation
this is
related to,
aortic arch.
okay, so this,
Aortic arch, yeah.
and this is the level of carina and left main. There are
Mm.
a little bit here impression. What is this?
I think this is left atrium.
Maybe okay.
At the level of the left atrium, it's distal.
Excellent. Okay, so we have here, where is the AP? What we have here?
Um, this is at the level of upper mediastinum or paratracheal. Um,
So we have some indentation here, okay?
yeah.
And from my side, I have a doubt about this, okay? This is okay for you?
Mm.
You
Yeah.
consider this is the left
Yeah.
edge. But if I am in your situation in the exam, I will tell the examiner better this is another abnormal indentation. Okay, what will you do
Mm.
next?
SCT.
Okay, we will do CT. What happened here? Look,
So the
look,
esophagus is dilated.
not dilated. Look again.
Um,
What is it?
Second.
Yes,
This is second. I can't see the contrast in this at least at this level. So there is intraluminal
yes.
hypodens
Not
filling
hypo.
defect or isodens
Iso
filling defect.
muscle.
Yeah.
Okay.
Yeah.
So we have we have intramural
F-
ISO 10
filling defect. Yeah.
ISO مش ISO 10 يعني ISO intensity and
Then, yeah.
اه
Okay.
the same density. Okay. Same density
Okay.
of the skeletal muscle.
Okay. So this. Hello.
Yes. So this is ISO dense.
Yeah.
ISO dense to the smooth
Mm.
muscle, to the skeletal muscle. What is your differential diagnosis?
Um, it has smooth contour. It doesn't have any
Excellent.
external um,
So
infiltration, so it looks benign for me.
excellent.
So
What is the benign
it
tumors?
might be, yeah, it
Yes.
might be myoma, esophageal myoma, or just tumor, or but just most probably extraluminal.
Excellent.
It has
So
extraluminal component or a polyp, but
yeah,
this is a
not
SSI.
poly. No, 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 no.
Like, but
No.
myoma is the most probable.
Myoma. Myoma. Why?
Leiomyoma, yeah.
Why? If this polyp, you should see here in this one. Which one? You see, if polyp, you should see here filling defect. But
Mm.
what we saw here, we saw indentation. A
Yes, a
smooth,
smooth white based,
smooth,
yeah.
a smooth indentation
Mm. Mm,
The
mm,
mucosa is intact, so it is either mural or from outside. See, my colleague,
mm.
thank you, doctor. It was a difficult case.
Thank you,
Don't
doctor.
worry. Welcome. See what happened here. We are examining. We suspect this one, and we suspect this one. This is acceptable, by the way. The examiner will not kill you. It is better to suspect than neglect. Okay, I told you before I lost two cases, but thanks God not in the same way. one one in June and one in the second time, because really I suspect it was a subtle finding. I suspect and I keep silent. I lost the cases completely. So suspect, tell the examiner and
Mhm.
he will help you. Thank you so much, my colleagues.
Doctor, I want to ask, the upper one is, it was nothing, right? Upper
This
one.
one,
The upper indentation at the, yeah,
yes,
anterior.
this one
This
is.
was nothing, right?
I think this it was the normal inclination of the esophagus, because the esophagus normal course sometimes came to the left, sometimes it came to the right. Okay,
Mm.
like this.
Mm,
So in X-ray and the barium and all this study, it is your right to suspect anything.
mm,
Why? Because it is not anatomically fully oriented like CT. See here. In city, you can't, it is not allowed to
mm,
tell examiner, I suspect it may be. No, this is a
mm,
mess. This is a mess.
yeah.
Be clear. Okay? Look
Mhm,
here at the upper part. Oh, yeah. See, this is the upper part
mm.
deviated to the left by the trachea. Thank you, doctor, so much.
Thank you,
Thank you
doctor.
so much, Dr. Nagam. My colleagues, special thanks really, really for Dr. Nagam. I think this is more than continuous, consecutive 10 sessions she arranged in complete silence. Really, special thank you, Dr. Nagam. Thank you for
You
all
are
of
welcome, Doctor.
Thank you. Thanks again to Dr. Nahla, which opened the group for all of us and gave us this great access. My colleagues, I will